back again with HDYO's Breaking Down Barrier series and having another casual conversation with one of our pharma companies that are developing drugs and therapeutics for Huntington's disease. And it wouldn't be a casual conversation without my trusty companion, Ashley Clark, who will reintroduce herself.
Hi everybody, my name is Ashley and I am here in Northern Ireland and I am on the HDYO board and help run their ambassador program as well as lots of advocacy work and stuff you've probably seen me about.
And I forgot to mention that I'm Lauren Byrne and I am also from Northern Ireland, but currently in London. And it's just a coincidence that we both are from Northern Ireland. So we do our best to keep our accents under control. But I'm pleased to introduce members from the Neurocrine team, Cara and Dwight. We'll start with Dwight because I think he has an interesting connection to our homeland.
Yes, thank you. Good morning, good afternoon, everybody. Thank you for the opportunity. And yes, that is true. My mother is a Kennedy from Northern Ireland. I'm pretty good, I think, at suppressing the accents, but every once in a while it does come out. But I'll do my best. And I was actually born in Canada, so I was not born in Ireland, but I've been to Ireland many times. Love the country. And as I said, my mother definitely comes from there. Definitely have a connection and still have family in Northern Ireland too. So thank you. My current role. I'm with Neurocrine. I'm the Associate Medical Director of the Neurology Program at Neurocrine.
All right, and I'm Cara Pasquale. I am on the patient engagement advocacy team at Neurocrine. I'm a senior manager there, focused in the rare disease space. And I've been at Neurocrine now for about 2 years. I've actually come from a patient advocacy organization in the respiratory space, where I focused a lot on including the patient caregiver voice in the research process. And while I don't have a strong claim to Ireland, my mom is Irish and Scottish, so there is some on that side, and maiden name Beecher.
Yeah, that's clearly the remit of how you get on these conversations.
I think it's criteria for tonight's conversation.
So before we get on to what Neurocrine is and what it's been working on, I thought we'd start with just introducing the term Chorea because we're going to talk about it a bit. So people from the community might have heard this before. Chorea is a term that describes the unique movement disorder or movements that happen in Huntington's disease. Chorea actually comes from the Greek word to dance, so choreography, if you think of it that way. And you can think about the movements in Huntington's, they're more what we call in medical terms hyperkinetic, too much movement. And they can be more erratic, so they can be dance-like and rhythmic. And often, I think Ashley will definitely know a lot more about this, considering used it as her blog slogan. But often our HD members or patients can look like they're drunk, and often that's from this erratic movement. So maybe Ashley, you want to tell us a bit more about your experience with that?
Yeah, for anybody that doesn't know, my dad had Huntington's disease, and that is where my connection comes from. So I live at risk, and I grew up as his young carer from the age of 15. One of the most noticeable things we probably seen in dad in the early days and what led to him getting tested was his chorea, but we didn't use that word, or it wasn't used here anyway. I know everywhere around the world is different, but his movements were very noticeable. One of the problems we had with dad's chorea was daddy was actually in a plane crash, like 30 something years ago, and he was always like jumpy and fidgety, like that's how I would have described him. And then when you added the chorea into that, it just kind of heightened that and made that even more noticeable. But he was, publicly called drunk, and people would stare at him and stuff because like he'd be sitting and the next thing he'd just stand up very abruptly, or if I asked him to move like one specific limb, like his arm or his leg, something totally different would happen. But he did definitely, his facial expressions were very noticeable. His face never really stayed too still. His eyebrows or his mouth or, something was always moving and stuff. So it was definitely one of those like major signs in dad that you would very much notice. And I know it can differ from patient to patient though, Lauren, because I
Yes.
have very brief memories of my grandmother who also had Huntington's, and she was as calm as water. She was so still. And then my dad was kind of the opposite, but as the years moved on and as the disease progressed, his chorea did reduce, if that makes
Hmm.
sense.
Well, that's actually very much part of the disease, and it relates to, we're not going to get into that because that's
Look
too
at me being
much.
all sciencey.
But the part of the brain affected leads to there's a specific type of neuron that's affected first in HD, and there's a thought that the way that network works, if they go first, that creates the too much movement, because the area that's affecting the brain is really the hub, the central control system for how people move and decision.
Yeah.
And then later on, once all of those neurons are kind of gone, then the second type of neurons are affected, and they believe that's why there's a bit more slowness of movement and stiffening later in the disease.
I
But you're
do
absolutely
think,
right. It's very different patient to patient.
yeah,
And one thing that's common that people don't realize is like the person themselves sometimes don't actually have insight to those movements.
oh,
It's
dad had
actually,
no idea at
yeah.
times. Like, I'd be like, Daddy, sit down. And he'd be like, I am sitting. And I'm like, dude, you're standing beside me. Daddy had no idea. Or he would like pull like angry faces. And I'd be like, what's wrong? Nothing. And I'm like, are you happy? And he'd be like, yeah. And he'd be sitting there thinking he's smiling. And, he'd have like a big cross face on him. But yeah, it dad never seemed to have an idea sometimes of like what was going on. I wouldn't have called them Chorea. I would have called them uncontrollable movements
Mhm,
because dad couldn't stop it. And sometimes he didn't even know he was doing it.
mhm. So I think that's in terms of how it affects families, it's definitely the caregivers around and the people that really get affected, and it also impacts all the other
Yeah.
things like dropping and falling and swallowing, being able to function. So
I
it's still a very big impact on the families.
I think for me, and like I don't mean to generalize and put words in the rest of the community's mouth, but I think for me, the Korea was probably one of the hardest because, like you said, it affects so many different parts of the body. And, you know, I remember one time somebody asked me and they were like, if you could take like one thing away, what would it be? And I remember answering and saying it would be daddy's movements because he would be fit to take a drink himself without risking spilling it. Or, he was in like his mid 40s and he'd have to use like a sippy cup that you'd give to a small child because it had to have a special handle and a special lid. And, I think if we could take one thing away, it would have been the Korea that, dad would have said he would have wanted to take away. I know it's what caused him a lot of like, is aggravation the word?
Yeah.
Yeah, aggravation. But yeah, so Korea's a tough one. It's a hard one to, adapt to and figure out sometimes.
Hmm. So on that note, what are Neurocrine doing about it? Maybe tell us a bit. I don't know who wants to start, Dwight or Cara, if you could kind of introduce Neurocrine and kind of how you got into Huntington's disease.
Sure, I can take that question to start. And thank you for that summary of Korea. I think you pretty much covered every aspect of Korea in your discussion there, from how does it manifest, what does it look like? And, it can affect several body parts, as you said. It can many times be in the extremities, the hands, the legs, the truncal regions. It can be mild, moderate, severe. Many studies and surveys that have been done, both from the caregivers and the patients, have reported that it is impactful. It does affect their activities of daily living, early on occupational. It's socially stigmatizing. I mean, you guys just touched on every point that you possibly could. So thank you for that summary. That was a really, really good summary of chorea as an involuntary, uncontrolled, and certainly unwanted collection of movements. So for Neurocrine, I mean, maybe just a little bit of background who Neurocrine is for people that are not familiar with the company. It was originally founded in 1992. And since its inception, we've pretty much remained true to our original vision of conducting brave science to relieve suffering of people with great needs but few treatment options. And that really remains the vision today. I joined Neurocrine 6 years ago. Back at that time, it was a pretty modest company. We had about 600 employees. Fast forward to today, it's about 1,800 employees. So we've grown pretty quickly over the past 6 years. And we remain a fully integrated organization with research, development, and commercial capabilities that really focus on these novel therapeutics in many areas, specifically neurology, but also neuroendocrinology and neuropsychiatry. Those are really our three therapeutic areas that we focus on. Now, to answer your question about how did we get into chorea, it's somewhat of a serendipitous route, if you will. We had an approval dating back from 2017 from the FDA for a compound known as Ingrezza. It's an oral capsule that you take by mouth and swallow. It's a once-a-day pill. And that was approved for the treatment of a similar hyperkinetic movement disorder known as tardive dyskinesia. Now, TD, as it's also known, as I said, is an involuntary movement disorder, and it generally affects people that are taking medications for mental health. Many of these are antipsychotics. But following that approval and additional evidence in the clinic and providers telling us how great it worked and it suppressed these movements in TD patients, we felt that it was important and necessary to move forward and say, well, how would this work in patients with Huntington's disease chorea? Because again, it is a very similar type of movement. It's a different disease. Obviously, the cause of it, and Lauren, you were great, talking about some of the pathology and where it starts. I always like to use the reference to a brake and a gas pedal. So early on, what's really happening is that braking mechanism that prevents too much dopamine starts to default in the disease, and that's why we get too much dopamine. So drugs like Ingrezza will reduce the amount of dopamine and control those movements. So we thought that it was important to really study the efficacy and safety of Ingrezza for patients that are suffering with chorea and Huntington's disease. And that's really how it got its start. Just a really quick background. The first study that we did was a phase 3 study. That was in 2021 when we first did that study. And that was a 12-week study that enrolled 128 patients. So we had split it between two groups of patients. 68 of those patients would receive Ingrezza for the treatment of chorea, and 68 would get a placebo over a 12-week period. And what we were really interested in was looking at a change in a measurement that many neurologists will sometimes refer to as a total maximal chorea, or TMC for short. And that's just a way of measuring chorea in different body areas to see how severe those movements are in each region of the body. And of course, our goal was to see, well, in treating patients with Ingrezza, did it reduce that TMC score? So higher is bad, lower is good. The lower the score, the less chorea you have. And the goal really there was to test the safety and the efficacy of Ingrezza over a 12-week period for treatment of chorea in Huntington's patients. And that's really how we got our start, just taking what we had known in TD and applying it to the chorea group.
Just as a reminder as well for anybody watching, as we talk about these terms, they're quite complex. HDYO provided a research terminology resource that is on our website, and we can maybe perhaps link it to the video. I might get or somewhere in the YouTube. I don't know.
Put it in
maybe
the description or something.
in the description. Yes, I think that can happen. So sorry, but
no, I was just thinking the same thing, Lauren. I was like, our little, I call it the cheat sheet, our little cheat sheet for scientific terms. I was just thinking the same thing. I was like, we should mention that.
Yeah, because we talk about kind of clinical trials and things like outcome measures, like you've just touched on, right?
Yeah.
I think what maybe isn't obvious to the community is when there's a drug that's already been approved for another disease, why do you have to do another clinical trial? So that would be, I think, interesting for people to understand.
Yeah, that's a great question. It doesn't surprise me people would ask, well, if it's already approved, why do you have to restudy it? And it is required by the FDA that anytime you have an approved drug for one disease, but want to study it in another disease, obviously TD is not Huntington's disease, of course, very different pathology. You have to perform several clinical trials to establish first the efficacy, does it work, but also the tolerability and safety. So part of that study is knowing, does it work? What are the measures that you're looking at to prove that it can reduce chorea, but also what are the safety signals? Like with any drug that people take, there's always some risk to those drugs. There's side effects that occur. And, the FDA certainly wants to know, not only does it work, but in this new disease population that you're studying, in this case, Huntington's disease, what are those safety signals? What are those risks or adverse events, as I like to refer to them, on the FDA side? What do they look like, and what sort of things should be reported so that patients and physicians, when they're making decisions around treatment options, fully understand not only how well the drug might work, but what some of the potential side effects might be of those drugs. So we partook in two clinical trials. One was called Connect HD, HD, obviously Huntington's disease. That was a short-term study. I mentioned it. It was a 12-week study, so fairly brief. But then we also wanted to look at what are the long-term benefits and side effects or safety issues with the drug. So it's great to show that a drug might work in a short period of time, but we know that these patients are going to suffer from chorea for a much longer period than 12 weeks. So it's important that you study these drugs on a longer term, and our Connect HD2 was actually a 3-year study. Now, what was different about that, and I think this is important to point out too, is that many of these long-term studies are sometimes what we call open label extension. And what does that mean? Well, we don't have a placebo group. So oftentimes the FDA will want you to study your drug against a placebo or an alternate treatment. But then they'll also say, well, if you're going to do an open label, once we've established the efficacy and safety, what is the efficacy? So how well does it work? And what is the safety over a longer period of time? And we did that in Connect HD2, which was an open label study for 3 years. One other thing that was very important about this study that I'll call out is initially in the Connect HD, we didn't have patients who take antipsychotics. And we know that that's very common. Patients will take antipsychotics many times for behavioral and mental health issues associated with Huntington's disease. But in our initial study, we had excluded those patients. But in the open label, understanding that in the real world, patients are taking a lot of drugs, including antipsychotics. So we wanted to look at how do these patients do when they're also taking antipsychotics. So in the second study, that was a much longer term study, as mentioned, 3 years, we allowed patients to be on antipsychotics, which really represents what's happening in the general population. So it's much more of a, if you will, in some ways, a population study where we're saying, okay, they've got all these medications. Let's now treat them with Ingrezza, see how well it works in reducing chorea while they're taking these other medications.
This is probably off topic, but related, because I was just thinking when you mentioned about tardive dyskinesia and that a lot of them would have been taking antipsychotics, which is why they got that particular movement disorder. Would you say that there was a good evidence to suggest that this drug was tolerable with people taking those kind of drugs, or like there was, or
in the TD disease, Lauren?
Yeah, so that's why they get that movement disorder. They often take drugs that antipsychotics can often cause movements or certain types of them. I'm not an expert.
I was just thinking, because I'm very curious about this. I don't mean to interrupt, Lauren, but it kind of feeds on to what you've just asked. I have no knowledge of like what TD is, and I'm listening to you sort of hearing like, oh, okay, so it's like similar to HD in the way that it's got the chorea, and that's what sort of opened the door for you to be like, hey, we, done this with TD, and we, worked with them, and now we're going to branch into HD because it's similar, it's not the same, but it's similar, and we think we can help. But that's what whenever you said, Lauren, so
basically,
TD,
a lot of movement disorder neurologists really love Greek terminology to describe everything. So you think of kinetic, comes from kinesis. Kinesia is all about movement, same root. And then you have hyperkinetic, too much. Dys comes from like an unusual, would that be, or a different movement? You can get hypo, but in this case, so tardive dyskinesia is tardive, I'm not sure, but it means slower, odd movements. I don't know.
Yeah, tardive is delayed. So it's like a delayed onset. Yeah. So that's where the phrase tardive dyskinesia comes from. And you asked a very important question. One of the things that we had to also demonstrate was that if patients are taking other drugs, in the case of TD and HD, and they're on antipsychotics, one of the important questions to answer is, does adding Ingrezza, does it destabilize those patients, right? So you don't want to add a drug where suddenly their mental health becomes worse. And we've done several studies in the TD space that showed that patients were stable on their medication, and that their mental health was also stable while they were on the clinical trial. So adding Ingrezza didn't disrupt the mental health, which is very important. Again, if you're going to destabilize a patient, it's not a very good drug to give to them. So knowing
also
that,
very important for Huntington's disease, because
100%.
Ashley talked a lot about kind of how movements were really impacting her experience of her dad, but actually for me, it was the mental and psychiatric side, and my dad was on antipsychotics, so to have that was like a lifesaver drug for us. To have anything that would destabilize the psychiatric elements would be, we don't want that. So it's interesting from both sides, the scientific and kind of personal side. So you're saying that in the second trial, looking at Ingrezza,
Yep.
Ingrezza, with patients that are also on antipsychotics and other drugs. What did you see?
And can I ask a wee two-pointer on that one, Lauren? Can you accept a wee two-pointer? You said I've need to remember to ask this. Has been in my head. You said that in the second trial, in the 2.0 trial, you've done it over 3 years, and it was to see if it works with people on the other medication, but you didn't do a placebo. So now maybe I'm wrong here, Lauren, you'll jump in, but whenever there's like a placebo, it's like we have the people that's on the drug, and then we have the people that's like not, but they don't know, like we don't know who's on what sometimes we do, whatever. What were you measuring? Do you know what I mean? Like, what were you measuring it against if you didn't have the placebo? Is that,
that's a very good question, Ashley. That's a very good question.
It's a great question.
I'm getting a lab coat for Christmas.
Yeah, we may have an opening for you at Neurocrine.
No bother, I'll send the CV.
It's a great question. Again, the 12-week study, because it established the efficacy in a placebo. So these types of phase 3 studies, you'll often hear them referred to as a double-blind, randomized, placebo-controlled study. That's a bit of a mouthful. And again, the randomized just means that you're randomly selecting which patients are going to get a placebo, which usually looks exactly like the treatment. They just don't know that it's not the treatment because it looks the same. And you do that to control for differences in how the pills might look. Otherwise, patients know, aha, I'm getting a placebo. Same thing with the physicians. When you say double blind, it's usually the physicians and the patients don't know which medication or placebo that they might be getting. Once the 12-week study established an efficacy, that it actually did successfully reduce the TMC, so it improved chorea over 12 weeks. In fact, we saw improvement as early as 2 weeks on 40 milligram dose. So even at the lowest dose, as early as 2 weeks, we saw a reduction in chorea, which is quite impressive. But then, of course, the next question becomes, well, now that you've done your placebo-controlled trial, and you've only done that for 12 weeks, again, patients are going to suffer from chorea for a much longer period of time, right? And Lauren, you mentioned earlier that, some cases patients will transition from chorea to what looks more like Parkinsonism, which is a hypokinetic as opposed to hyperkinetic movement disorder. But we wanted to know, over a 3-year period, would we see sustained improvement in these patients after we had seen it on 12 weeks? So what's interesting, about 2/3 of the patients that were on Connect HD went into our open label study, but we had about 1/3 of patients that were not on that study that were allowed to participate in the extension trial, our Connect HD2. And again, what we thought would be important is, well, we know these patients are going to be on antipsychotics, so it really makes no sense to study it long term and say, we don't want anybody on antipsychotics, because most of these patients probably are taking one or more antipsychotics, again, for the behavioral and mental health issues associated with Huntington's disease. We knew that the efficacy was there. The question becomes, well, take the population of patients that are receiving all kinds of medications. Add Ingrezza, we don't need the placebo because we've established the efficacy using a placebo group. And what would we see now in a long-term study with patients that are taking these antipsychotics? And not all of them necessarily were. We just allowed for that. Okay, so patients could come in not taking antipsychotics. They could have started on the antipsychotics and then started the trial. And in some cases, patients started our Connect HD2 and then they went on antipsychotics later because there was a medical necessity to add that to their drug regimen because of the symptoms that manifested during the trial. So we kind of had three different populations, right? We had patients getting Ingrezza that weren't on antipsychotics, patients that came into the study with antipsychotics and had valbenazine or Ingrezza, as it's known, added to their regimen, and then those that started on valbenazine but then needed an antipsychotic added later. Now, we didn't add those. That was at the discretion of the physician participating in the study. But again, what we found was, irrespective of whether they were on them, started late, started early, we still saw the same degree of change in chorea movement. So that even adding Ingrezza to a regimen where antipsychotics are already part of their treatment still resulted in an improvement in chorea as far as 2 weeks. Now, we've enrolled all the patients. We haven't quite gotten our data to the 3-year endpoint, but after 2 years of patients being on the study, we still see a sustained improvement, which was quite fascinating because we know this is a progressive disease, right? It gets worse. But the fact that treating them with Ingrezza and then 104 weeks later, so 2 years, their chorea is still much less than what it was when they started trial. So we have effectively reduced it and maintained it and stabilized it. Was quite impressive over 2 years. So stay tuned for the 3-year data.
That's really great.
That's really impressive. So it is. Dwight, it sounds amazing, and it sounds like the trial is going really well. You're at the 2-year mark, so very excited to hear what that 3-year mark will bring. But if you don't mind me asking, what side effects have you seen? Because you've done the 12 weeks and everything looked good, and you've obviously now decided to do a 3-year. So what are we seeing in that long-term taking of Ingrezza?
Yeah, that's a great question, Ashley, and thanks for asking that. In fact, we did notice side effects even in the 12-week study. So, when you do these trials, you have to also capture any safety signals they refer to them as. These are the side effects or the adverse events that sometimes you'll hear them referred to as. And what we saw in both studies, so the 12-week randomized placebo-controlled study, but also the open label extension 3-year study, to which we have 2 years of data right now, there were, in fact, some safety signals, some side effects that we did report. And the most common ones that were associated with Ingrezza in all of the patients were sleepiness. Sometimes you'll hear that referred to as somnolence, but it's just sort of that, if you ever had that feeling where you're just sleepy all day long, you can't shake that feeling of being tired.
Could we say drowsy, or is that a bad
drowsy? Yep, drowsy. As I say, medically, sometimes you hear people refer to it as somnolence, but it's the same thing: drowsy, sleepiness. We did also note there was some allergic reactions, some itching, some rash, also some trouble getting to sleep and staying asleep. Sometimes what's referred to as early insomnia or middle insomnia. So if you've ever had that experience where you kind of wake up in the middle of the night and can't fall back asleep, sometimes people refer to that as middle insomnia. We did notice that in the patient populations for both of these studies. They were common across both studies. But another thing that I'd like to call attention to is that Ingrezza is what we call a VMAT2 inhibitor. That's a vesicular monoamine transport 2. And there's 2 types. That's why one's VMAT2, VMAT1. This one targets VMAT2. It inhibits that system. But as a result of that, what was observed for all VMAT2 inhibitors, as well as Ingrezza on the study, is what's now called a black box warning. And that is because there's a potential with all of these drugs, Ingrezza included, for an increased risk of depression and suicidal thoughts or actions in people with Huntington's disease. We know that, in general, HD patients do have a higher risk of depression and suicidal thoughts or actions. So it's important that any time that a patient is interested in this drug, Ingrezza, to obviously speak with your healthcare provider to determine if Ingrezza is the right treatment. We certainly noticed an improvement, but yes, there are side effects, and these side effects can affect people very differently. And there's always that risk for severe depression, or more importantly, suicidality, either ideation, thinking about it, or actually attempting suicide. So, of course, we always recommend that please have these conversations with physicians to make sure that Ingrezza is right for that patient, because these are black box warnings associated with VMAT2 inhibitors, the depression, the suicidality, both the actions and the ideations.
My understanding is that the other drugs that are currently approved for chorea specifically also have similar side effects that are related to increase in depression, which is just sparks my interest as the science kind of thing. It's like how linked these mechanisms are, because I think people that aren't as obsessed with brains as I am don't realize like how the same part of the brain is all linked to kind of managing behavior, mood, as well as movements. It's like this real important control hub. So it's obviously why it's been so difficult to kind of treat these kind of disorders. But
Yeah. No, it's a great question. And when you see common side effects that are common to in this category VMAT2 inhibitors, you'll see the term sometimes class effect or class side effect. And this is one of those with, again, the depression, the suicidality, and the suicidal behaviors is what's known as a class effect with these VMAT2 inhibitors for Huntington's disease. So people might see that term, and that's really what it's saying, is that this is common across all VMAT2 inhibitors, that there is some degree of risk for those things to happen. And of course, both patients, families, and healthcare providers need to take that into consideration when prescribing these medications for patients.
Absolutely. So what now? What's the next step? So is it just finishing the phase 3 trial? Have you had talks with the FDA? Where the next steps?
So we had the drug approved based on Connect3 in August of 2023, right? We filed the new drug, the supplemental new drug application in 2022, and it was ultimately approved for the treatment of chorea in August of 2023. Obviously, the ongoing data is stuff that will continue to report. You always have to update the FDA with new findings, whether it's efficacy, but most importantly, safety, right? They always want to know, does this drug continue to be safety? Was there any new safety signals or observations that weren't reported previously that would require potentially an update to a label if those were observed? So, right now our goal is just to finish up the study and continue to report out data for 3 years. As I said, it was exciting to see what we had over 2 years, as well as the safety issues that arise. But what we're really curious now about is, well, how does it look after 3 years of use? So that's where we're going at this point.
And now that it's approved, did you want to jump in, Ashley?
No, not right now, because you just said now that it's approved. I was going to be an absolute gob and be like, is this on the market yet?
Well, that was my question, is like, when a drug gets approved by an organization like the FDA, does that mean that
that's because when you
you
said
can
it was
go to your
approved by the
doctor?
FDA, I was like, oh my God, can we go out and get this? Like, can I go to my doctor and ask him for this?
I'll let Kara take this one.
Yeah, so I can jump in here. Thanks, Dwight. So the answer is, it really depends, right? Each situation is different. For Ingrezza, since as Dwight mentioned, it had already been approved for use in the treatment of tardive dyskinesia back in 2017. So when we received the approval in August of 2023 for HD chorea, we already had the infrastructure established around the manufacturing and distribution. So Ingrezza was readily available for patients with HD chorea at that time of approval. But that's not always the case. There can often be a gap in time from when a drug is approved to when it's actually available to patients. And this gap can range from days to weeks and months, and it really depends on lots of different factors. A lot of them are related to the supply chain and manufacturing. So since Ingrezza was readily available at the time of the HD chorea approval, what we could focus on at Neurocrine was really increasing treatment awareness amongst healthcare providers, specifically neurologists and movement disorder specialists, as well as the patient and caregiver community around that this treatment was available. Now, I think one thing which Dwight will go into in a little bit, but we also have a sprinkle formulation of Ingrezza called Ingrezza Sprinkles, which is these oral granules. And that was approved for use in April of 2024. And then a few months later, it was made available to patients in July of 2024. So both Ingrezza and Ingrezza Sprinkle are currently available to patients through a network of specialty and local affiliated pharmacies that we have in the US.
So it's not available outside the US. Maybe in Northern Ireland, I couldn't get, it's not outside the US. I'm like,
yeah, no, it's currently only available in the US at this time.
Have you plans to expand that?
Yeah, so right now we have no immediate plans at this time for the commercialization outside the US. But we understand that the need exists beyond the borders of the US, that clearly there's a treatment need for HD chorea beyond the US. But there's a lot of different factors that are being weighed, and at this time, it'll just commercialization within the US, but we'll keep the community updated on any global clinical development plans or commercialization.
Can I just ask a bit more about
Are you thinking about the sprinkles?
sprinkle formulation? Like why?
Yeah,
And
can
tell
you
us
explain that to me? Because so Ingrezza is a pill, but I'm picturing sprinkles on a birthday cake. Can you take that image out of my head and explain it to me properly, Natalie?
I'll
That
let
might,
Dwight take that one.
yeah, thanks. I appreciate that's a great question. Maybe that's a new marketing approach. I don't know. Sprinkles like
I
a birthday
do work
cake.
in
That's
marketing.
different.
That CV
Yeah.
is still
Well, see,
available.
yeah. Well, that's a great question, and taking pills can be difficult for a lot of people, right? I mean, some people just don't like swallowing pills. They may not have a condition that prevents them; they just don't like to swallow pills. But I think the challenge is even greater in Huntington's disease, especially patients with chorea. Now, we did say that many times chorea manifests in the extremities, but it can also appear in Huntington's disease in the oral buccolingual, so the face, the mouth, the tongue. And if you have chorea of the tongue, it makes it difficult to move a pill to the back of your throat to swallow it. In fact, surveys that have been done with chorea in HD patients have indicated that about 62% of patients report swallowing difficulty because of these involuntary movements. So it's a high percentage of patients. And as the disease progresses, many times these movements will move away from the extremities more towards centrally, so truncal, facial regions. That'll make it very difficult. And recognizing this challenge, we felt that it was really important to offer an additional method for taking this medication, especially for the Huntington's disease population. So we actually did a clinical study. There was 38 healthy volunteers. Again, this was just a swallowing study to make sure that the sprinkle formulation could be taken. And really what it is, it looks like a capsule, but you open the capsule and there are small beads that you can now sprinkle on food. So the original formulation, you take it orally once a day. It could be taken with or without food. This is intended to be opened and to be mixed with some food. That way, soft foods, say like, yogurt or pudding or something that is much easier for a patient to swallow. So we did the testing on this, as I mentioned. It was 38 healthy adult volunteers, just to look at how well the sprinkle formulation of Ingrezza was absorbed in the body, because you want to make sure that it does the same thing as the original formulation. And in fact, it did. So that allowed us to be able to say, well, look, we now have this alternate formulation where they can take it if they prefer the oral capsule, that's still available. But for the Huntington's patients, if they prefer something that's a little simpler, just open that capsule, sprinkle it into your food, mix it up. And it's good for about 2 hours. So we recommend if they do that within 2 hours, they should be consuming that food that has the Ingrezza in it. And again, it's just an alternate option for patients who experience what's called dysphagia. So that's that swallowing difficulty, or just prefer not to swallow pills. I mean, you don't have to have dysphagia if you didn't like swallowing pills. This is just an alternate formulation that helps get that drug into the system where it's needed in patients.
Yeah, I think it's great. It was my first thought of like, oh my God, that's such a good idea.
Literally, my brain is going here. Like, Dad was one of those patients who really struggled to swallow pills, and it was like we come up with like every technique. Like, it was get a bit of yogurt in the spoon, sink it really deep into the yogurt, and hope that it went down. So like the fact that you guys have like sat back and said, okay, we've got this pill, the pill works, the pill's on the market, but the people that we're targeting with this pill can sometimes have issues swallowing. Like you said, though, they might just not like taking pills. Like, I remember there was a time my dad was on 20 odd pills a day. He was sick of popping pills. So like the fact that you sat back and you were like, we're gonna make I'm calling them sprinkles. I'm sorry. We're gonna make sprinkles, and we're gonna make this really easy and safe way for these people to get this medicine.
Yeah,
Like,
yeah. Well, it is called Ingrezza Sprinkle, so you're not far wrong. You just open it and sprinkle on a food, and it reminds me, Ashley, to your point, many years ago, that's how my mom used to get me to take medication, right? She would break the capsules or the pills down and mix it with jam. It never tasted very good, but that's how she got me to take a lot of pills when I was younger. So again, this is just acknowledging the fact that the HD community and the patients affected by chorea do have challenges swallowing pills, and why not just make it easier for them? They can get the treatment to manage chorea without the struggle of swallowing a full pill.
Yeah, I think it's a really nice approach and a well thought out for this community. So as we finish up, any closing thoughts, anything we've missed that you wanted to share with the community or let the community know about?
Yeah, so I can jump in there on my side. Just that you know, at Neurocrine, we've been engaging with the HD community now for a number of years, and just really appreciate the partnership and collaboration that we have with all of the HD patient advocacy organizations, and we just really value those relationships and just appreciate all the time that they've spent with us so that we can learn about the community, really understand the priorities. And you know, just one thing we've learned from HDYO over the years is just how important it is to support the younger generations impacted by HD. So we're really proud to be a founding sponsor of the Youth Mentorship Program that offers that critical peer-to-peer support, because we just know how important that is for individuals. You know, just overall, we really value the partnerships with the HD advocacy organizations and all of the work that they do to support the community.
Yeah, I just echo that sentiment. You know, we're grateful that we could, you know, develop something that would be helpful for the HD community. They really go through a lot. You know, all of the different symptoms, the progression of disease. It's such a cohesive and welcoming community. It really is. So just to be a part of that and to be able to provide something that treats a symptom that's common, you know, I know in several of the publications, even Dr. Martha Nance, who probably many people know in her Physician's Guide to Managing HD, she reports in there 90% of patients suffer from chorea. So just to be a part of that treatment process, to be able to provide not only a new treatment for chorea, but a new treatment and a new formulation to help patients swallow this medication. We're just grateful that we can be a part of that as well.
And I'd just like to finish with, you know, on behalf of HDYO, we are so grateful for all the support. Neurocrine have been super generous for supporting our youth mentorship programs and various different projects that we've been involved with, and we've really enjoyed working with you. Any final comments, Ashley, before we close?
I'm honestly blown away. So you guys are amazing for what you're doing, and it's so obvious how much you care. You know, you not only just brought out a pill to help chorea, you know, you thought of a new way to get it to patients in a safer way. So, you know, as somebody in the community who watched their father, you know, struggle with something as simple as taking a tablet, you know, it does mean the world. And you know, I know it's not available outside the US, but you know, it's for someone who lives at risk of the disease, and chorea probably being one of the things that scares me the most. The fact that there's a chance that that might be available and be available in a safe option, you know, it's amazing the work that you guys are doing. So you know, you're so grateful for HDYO and stuff. Well, can I just say that I'm really grateful for, as a community member, for like the work that yous have done and like the work that yous have pulled off. You know, like yous pulled it off, yous did it. So that's amazing. And this has been great. I didn't have to summarize things once, Lauren.
I mean, you're getting your questions, Ashley, are really, you know.
Listen, I want a lab coat for Christmas with my
I will
name
get
on
you a
it.
lab coat for Christmas.
I really want one.
Just as we finish up, where can people find out more and keep updated? Obviously, we'll share anything that you release on the HDYO website and our Instagram, etc. But if there's any other avenues that people can keep up to date on the program.
There's a great question, and obviously Ingrezza.com is a great resource for patients to go to. It has information about Ingrezza for HD, and it covers the full prescribing information. So that's certainly an ideal resource for people to go to, Ingrezza.com.
Amazing. thank you very much, and we'll say goodbye for now.
Thank you so much.
Thank you, Lauren.
Wow,
Thank you,
thank
Lauren.
you.
Thanks, Kier. Thanks,
Mhm.
Ashley.
Bye.